Welcome to Project Echo Geriatrics. I am Kate Bennett. I'm the medical director for Project Echo Geriatrics and a geriatrician here at Harborview. Welcome to all of you who are joining us for the first time. I see some familiar face from Swedish. Welcome, Eric. Thanks for joining us. If you want to join in by audio and you don't have a microphone, you can call in. It looks like you already did that. But thanks to all of you for joining us. I'm going to go ahead and just get started on the talk, which I'm giving today, and then I will introduce the panel, and we have a great case coming up from Dr. Escobar, who I see has joined us too. All right, so I am speaking today about cancer screening in older adults. This comes up a lot in a primary care setting in particular, and since all of you generally practice in a primary care setting, I thought it would be really relevant. The question about who you should screen is so very complicated and not always well outlined by guidelines. So what I'm hoping to do is just to present to you a framework for how I think about this, how some researchers in this field think about it, so that you can maybe apply this to your patients. And this framework can also be applied to other conditions beyond cancer screening. We're going to use some polling software. So I have a question for you. If you go to your smartphone or your laptop or anything like that, you can pull up the URL rwpoll.com. And the session ID is UWEcho, all lowercase, and it should pull up the first question for you. So I'll read the question, and then you can answer. So you're seeing Mrs. Jones in clinic. She's a 77-year-old woman with hypertension who is able to independently perform her activities of daily living, has a normal mini-cog, and has brisk walking speed. Would you offer her colon cancer screening? The possible answers are A, yes, B, no, or C, unsure. Go ahead and respond. Looks like some of you got in. First test of the day. This is a very low stakes test, just to keep things interactive. All right, looks like quite a few decent number of responses, so I'm going to move on. Can I just hit the forward arrow here? Okay, so the majority of you said yes. There's no one correct answer for this because it depends on a lot of things, some of which we don't know. But yes, this woman probably has more than a 10-year life expectancy, and at least discussing cancer screening for her is reasonable, and I'll go into that a little bit more. So there's really a lot that goes into thinking about cancer screening in the elderly, and one of those things is looking at the guidelines. So lots of different societies put out guidelines for cancer screening. They often match up, but not always, and there are some finer details that don't match up. So I put some of the more common ones for breast, colon, and lung cancer screening here. And what I highlighted and what I'm going to emphasize instead of reading the whole table is where they put the upper limit age for screening or where they recommend you stop screening. So, for example, the United States Preventive Service Task Force for breast cancer recommends mammograms for women aged 50 to 74. And then after the age of 75, they say there's insufficient evidence, so you're kind of off on your own and to use your own judgment. For the American Cancer Society, they recommend mammograms until your life expectancy is less than 10 years. So they actually put a time on their upper limit of recommendations. For colon cancer screening, the United States Preventive Service Task Force routinely recommends it for people age 50 to 75, but says that you should individualize screening decisions for people age 76 to 85, and they recommend against screening in people over the age of 85. Whereas the American Cancer Society does not list an upper age limit for cancer screening. For lung cancer screening, which is something we've been doing only quite recently in primary care, the age range for this is 55 to 80, but they recommend, the U.S. Preventive Service Task Force recommends that you stop if someone has a limited life expectancy. And they don't really define what that means, but basically anyone who wouldn't be able to tolerate surgery or who has a more limited life expectancy is what's stated in their guidelines. And then the American Cancer Society has an upper limit of 74 in their guidelines for lung cancer screening, and say that this can be continued within this age range as long as someone's in good health. And don't really give much as far as a timeline to life expectancy. So those are that's a broad brush overview of the cancer screening guidelines, just to give you an idea of what's out there. So when we think about screening, we're thinking about the benefits versus the risks. So clearly, we do cancer screening because there are benefits, and what the benefit is that we are detecting cancer early while it's still treatable. So for people who do go through cancer screening, we're hoping to catch things before they become a problem so we can be more effective in treating their cancer. So as an example, for breast cancer, we know it's effective. You have 2 fewer breast cancer deaths per 1,000 women between the ages of 70 and 79 who are screened. It's pretty good. For colon cancer screening also, you definitely have a reduced relative risk of mortality from colon cancer from both fecal occult blood testing and colonoscopy. So they've been proven to be effective for sure in detecting clinically meaningful cancers. And I just wanted to give a shout out to Amy Verrill, our program coordinator, who found this really neat graphic in what they use to promote colon cancer screening. This is the Canadian Cancer Society, and their campaign is Make Your Bottom Your Top Priority, and I thought that was pretty cheeky, huh? All right. I don't want to make you all have nausea during your lunch, but I thought that was kind of funny. Okay, so there are also harms to screening, and that's what we're weighing against. And unfortunately, a lot of these harms do increase with age, which is why we worry more about some of our older adults undergoing screening. So what are the harms? In breast cancer, the biggest risks are false positives and overdiagnoses. So false positives, about 200 per 1,000 women screened with mammograms will have a false positive, meaning they'll have to undergo further imaging or testing, but it turns out that it's not actually cancer. And there's also a lot of overdiagnosis, which means that 13 out of 1,000 women screened have an overdiagnosis, which means they detect a cancer, and it is a cancer, but it actually wouldn't have become clinically significant in that woman's lifetime. They are more likely to die from something else first. It's often either slow-growing cancers, things like DCIS, where there's a lot of controversy in even the treatment for those cancers. So there's quite a bit of that. In colon cancer, we worry about risks with the actual screening technique of colonoscopy. There's a lot of harm that can happen with colonoscopy, and that we're more and more seeing becomes more of a risk as you get older. So 3 in 1,000 older adults screened with colonoscopy will have a major complication, and major complications include perforation, serious bleeding, or even death. And there are even more older adults than that who have other complications such as cardiopulmonary complications that might lead to them needing to be hospitalized as a result of their procedure. So there certainly is a risk of very serious consequences that increase as you get older. The other thing to think about is the lag time to benefit. So really, the lag time to benefit is referring to the time between your preventive intervention and when your health outcomes are seen. Or in other words, when will this help my patient? And that's something you're always thinking about when you're treating your patients, particularly your older adult patients, and is particularly relevant for cancer screening. And sometimes this is hard to really parse out in the literature, hard really to know how long it takes for an intervention to help, but often by looking at the studies, you can figure it out. It's not always clearly stated in the articles or in guidelines. So for cancer screening, some very smart folks looked at all the literature and determined for older adults or for all those who are appropriate for screening, for breast cancer, it takes about 10 years to really see a significant difference in between people who are screened and not. And what they consider significant is preventing 1 death from cancer per 1,000 people screened. So it takes 10 years to see that separation. And similar for colon cancer. And I just put a graphic depiction from this BMJ article that was published by Louise Walters and some other folks from UCSF who really study this as part of their life's work, giving an example of breast cancer screening. So we're looking at when these lines separate and when they separate significantly. And at about 10 years, there's a 1-person difference between the screening line, the top line, and between the control group and the screening line, which is the red dotted line on the bottom. So it takes 10 years to really see a big difference. So if your patient isn't going to live more than 10 years, then they're less likely to benefit from screening. So thinking about it in a stepwise way, and this is adapted from some publications by Dr. Walter at UCSF, who talks about this quite a bit. When thinking about preventive interventions like colon cancer screening or breast cancer screening in older adults, an important first step is to think about life expectancy. How long do you expect this person to live? Because that informs the rest of your decisions. Then you want to think about, for any particular intervention you're going to offer to this person, how long is it going to take to help? What is that lag time to benefit? So for breast and colon cancer screening, we just talked about, it's about 10 years. And then thinking about, is the life expectancy greater than this lag time to benefit? Will they live longer than it takes to really see the benefit? If the answer is yes, then you can recommend this to your patient within an informed discussion. They may decide to do it or not, but you can feel pretty comfortable that they're more likely to benefit from it. If their life expectancy is borderline, is close to the lag time to benefit, then you'll want to have an informed discussion and really talk about, these are the risks, these are the benefits. I'm not sure if this will help you or not. What are your healthcare priorities? And that's a discussion you'll have to have. If it's very clear that their life expectancy seems to be less than the lag time to benefit, then it's appropriate to recommend against the intervention. It doesn't mean the patient won't still decide to maybe undergo it if they're really valuing longevity over all things or detection of cancer over all things. But at least they'll know your recommendation and the likelihood that this will help them. So here's question 2. You can, again, for those who came in a little bit later, go to rwpoll.com, and our session ID is UW-ECHO, and then you can answer the question. So the question here is, how do you usually estimate life expectancy for your older clinic patients? I see the responses rolling in. Good. Looks like you found the site. All right, good responses here. Okay, so most people said I estimate based on my clinical gestalt, which is really common. Some other people are using some, I meant to say online calculators, but I think I accidentally didn't type the ON part of that. But online calculators, C was the second most common. So I'm glad to see that some of you are using online calculators. But our clinical gestalt is really important. We use this all the time to make lots of treatment decisions. So let's break apart what goes into clinical gestalt and some of the things we know about general patient characteristics and life expectancy. So health status, we know, practically speaking, that if someone is poorer health, they're likely to have a lower life expectancy. This is proven in the literature, and this study was published in JAMA in 2001, quite a long time ago. But I pulled this out because it was the best graphic depiction of, based on quartiles of health, how long is someone going to live. So the yellow bar is the top quartile of health. These are people with almost no comorbidities. Maybe they'll have a little osteoarthritis. They're quite healthy. The middle quartile might have some comorbidities, but they're really well controlled. Maybe they have diabetes, but really well controlled, or hypertension, etc. And the lowest quartile of health are people with life-limiting conditions or more serious conditions, more severe heart failure, COPD, things like that. that might require more physician intervention and higher risk of hospitalization. So if you look at an example of an 80-year-old woman, for example in this, in the highest quartile of life, she's likely to live to be 93 years old, so over 10 years. So some treatments that might not help for 10 years might still be appropriate for her. I know I have clinic patients who still run 5Ks and are in their 80s, so we have a different discussion than my patients who have multiple comorbidities. The same 80-year-old woman with multiple comorbidities that are more serious might have, on average 4.5 years to live. And if they're more serious, of course, even less. But you can see, even with some well-controlled comorbidities, the life expectancy is shorter and less than 10 years for this 80-year-old woman. So it just gives you an idea that our clinical gestalt does match what we see with actual patients. You can also look at functional status. We think about functional status as a very important marker of how healthy someone is and how long they might live. And this is just a depiction of that in a table. And this is from a longitudinal study that was published back in 2010, looking at people's self-reported ADL abilities and mobility abilities, and then how they ended up, how long they ended up living, and how they lived during that time. So if you look at, again, an 80-year-old woman, and I didn't put up the table here for men, just the one for women for space, and this is just an example, but an independent 80-year-old woman who does not need help with ADLs and can walk many blocks and up and down the stairs fine without difficulty might live another 10 years or so, so at least 90 years. And most of that time she will be independent, this blue part. Whereas someone who needs help with activities of daily living, such as bathing, dressing, grooming, one or more of those, life expectancy is more in the realm of 6 years. So this does correlate with life expectancy and is important for us to look at. Another way to look at life expectancy beyond our clinical gestalt is to use actual calculators. So eprognosis.org was developed at UCSF, where they've done a lot of research into life expectancy, into decision making as far as cancer screening, and a lot of prognostication. And they developed this online set of calculators that you can use. The one that I use most often, I want to point you to, they have 3 different main calculators here. So they have general life expectancy calculators. They have one that you can use to actually go through the decision making for cancer screening. And then another section that helps you communicate about prognosis, basically tells you what to actually say to people once you've gone through these calculators, which is important and often left out. And if you go into the calculator for life expectancy, it asks you a series of questions. The first set of questions is, where does this person live? Because the calculators they inputted from the literature were based on these different settings. Then it asks you questions about BMI and different health conditions, et cetera. And you plug those in, and then it'll give you a sense of someone's life expectancy. Oops. And can you pull up the actual website for me, Adrian, the ePrognosis website, so I can show everyone, since we have a few minutes. How many of you use eprognosis.org? Some folks are Swedish. It's really, really helpful for prognosis. Okay. Oh, we're live. Can I control this? Oh, this is great. All right, calculator, technology. All right, so let's say this person is living at home. You click on that. You ask if they live in the United States. And then it asks you what is the time frame for the clinical issue. This is the lag time to benefit. So for cancer screening, we're going to pick, this is more in the realm of 4 to 10 years. And then it chooses calculators as you're going through this that fit this scenario. Is your patient 65 or older? Ours is. And then you input a bunch of information, and then it will give you an idea of the person's life expectancy or risk of mortality within the specified time frame. So for here, it'll tell you within 5 and within 10 years. And it tells you which index it used, so you can go back to the literature and see what the evidence is behind the index. But they only used calculators that are of high quality. And I'll show you this bubble view. This shows you a bunch of different calculators that they use on the website. It gives you quality of the index, so from high to low, and they tend to use the higher quality indices in the calculators. And then you can scroll over them and see who this applies to. So it's pretty neat. There's a lot of stuff on this website that you can take a peek at. I'm going to go back to, and I don't work for them. I just really like the tool. Although, full disclaimer, I've met the people who put this calculator together, and they're very nice people. All right, what do I have to do? Oh, all right. Okay, so let's go to one more question. So rwpoll.com, session ID UW Echo. We have an 83-year-old woman who lives in her own home. Her BMI is 28. She's in very good health. Her only medical condition is osteoarthritis and controlled hypertension. She does not use assistive devices and has had no hospitalizations recently. She's independent in all of her activities of daily living, including the instrumental or higher level activities of daily living. What is your best guess of her 10-year mortality risk? So what is the likelihood that she might die in the next 10 years? Pulling this open, waiting for a few more to trickle in. Okay. Okay. Oh, you're good. Wow. Okay, 44% of you put answer C, 55%. And that's the correct answer. I plugged this into ePrognosis, and it said that it was between 52 and 58%, based on all of the different items in this question stem here. So good job. Your Gestalt is good. And some of you might have been plugging it in, but it would have been pretty quick typing if you did. All right, great. So basically going back to it, when you're thinking about cancer screening for older adults, think about life expectancy. You have some different tools, including your clinical Gestalt to use. Thinking about the lag time to benefit, when will it help, and then sorting out if life expectancy is greater than the lag time to benefit. And the last part of it is really communicating this carefully with your patients. I was going to an info session about eprognosis.org, and one of the presenters said, my trainee went in after we calculated things and said, congratulations, you don't have to do mammograms anymore because your life expectancy is less than 10 years. And that did not go over well with the patient. So how you present it